So I'm going to be talking about a little bit about how ectasia forms and what is the etiology behind it. And right, so ectasia after LASIK is a rare but a serious complication. Between 98 and 2005, 182 cases of ectasia after refractive surgery were reported, and Palikaris found that about 0.6% of these with ectasia among other eyes that had undergone LASIK. So ectasia is a progressive anterior shift of the cornea that is associated with central steepening, thinning, a myopic shift, and visual symptoms. It's important that we segregate these high-risk individuals who may experience ectasia after LASIK from the patients who can undergo this procedure safely, because this complication may occur in patients with or without any pre-existing clinical evidence of formophrastic keratoconus. So what produces ectasia? Is it just a thin stromal bed? That means, is it just a mechanical tissue loss, maybe on account of an unpredictably thick corneal flap? Are there undetected topographic abnormalities which contribute? Are there biomechanical properties, such as a poor hysteresis or a low corneal resistance factor, which can predispose one to getting keratectasia? Another hypothesis is there late stromal melting which leads to ectasia? But a report showed that there was no underlying inflammation in any excised corneal button after LASIK, which essentially suggests that there is no melting phenomenon or inflammatory phenomenon that leads to ectasia, and it's probably largely a mechanical issue. The difficulty lies also in identifying what is abnormal. There is no single corneal shape that defines the cornea as normal, and that is one of the biggest problems in this. But there are areas that have now been implicated, and one of the most important areas is the back surface elevation, and the elevation of the posterior surface has gained importance in diagnosing early keratoconus and post-LASIK ectasia, and for this, topographers or equipments that look at the posterior float are extremely important, such as the OBSCAN corneal topographer and the pentacam, which Dr. Rajiv has so nicely spoken about earlier. In the red flags in the OBSCAN are the following when you start to suspect that there is a problem: a higher mean posterior elevation of more than 50 microns, inferior superior irregularity or difference of more than 1.5 diopters at the 3 millimeter zone and 2.5 diopters at the 5 millimeter zone, thinner corneas less than 500, ratio of more than 20% difference between the anterior and the posterior best fit spheres, and a large or a high posterior BFS of beyond 55 diopters. Many surgeons had earlier considered that anything less than 500 microns would not be a safe patient to operate. But should LASIK be performed in less than 500? And the surgeon must be certain that we are dealing with a normal topography, a normal slit lamp exam, stable refractions, and symmetrical findings between the two eyes. LASIK and PRK, even in thin corneas, may be safe and predictable. Now here's a series of less than 10 case reports of ectasia after PRK, and if you look at these two eyes of the same patient, we can see that one eye underwent a PARK and the other one underwent a LASIK, and there was ectasia in the eye that underwent LASIK, and there was no ectasia in the eye that underwent the PARK, even though that was a thinner eye. So the residual stromal bed or the anterior flap after LASIK does not contribute to the biomechanical strength of the cornea. And many refractive surgeons have accepted that a minimum post-ablation residual stromal bed of 250 microns in LASIK is adequate. However, this has been revised upwards, and now we look at anything less than 300 in the residual stromal bed to be suspect. If we look at a review of ectasias, 78% of them would have a formophrastic keratoconus, or they would be highly myopic eyes where the expected residual stromal bed would be less than 250 microns. 11% of these had a residual stromal bed of more than 250 microns, but with a total corneal thickness of less than 500 preoperatively. So essentially, a risk score can then be applied or constructed, which would look at many corneal parameters, and each one of them would then be scored. Patients with a cumulative score in this particular retrospective study by Khalid Tabara and Dr. Korb, with a cumulative score of 7 or less had successful LASIK and did not experience any corneal ectasia, while 59% of those with a score of 8 to 12 and 100% with a score of more than 21 experienced corneal ectasia. So there are some predictive mechanisms that one can use. Here's a validation by Randleman et al., where they looked at the preoperative topographic pattern, they predicted residual stromal bed thickness, the age, the preoperative pachymetry, and the manifest refractive spherical equivalent. And they put them into a chart, and they gave points. And so everything was ranked from 0 to 4, from topographic parameters to the residual stromal bed, the age, the corneal thickness, and the spherical equivalent. And they found that people with high scores on this were more prone to develop ectasia as compared to those with low scores. Corneal biomechanics is another area that has now been brought in. It's not in the classical ectasia evaluation programs, but a series of several complex biomechanical factors influence ectasia development, such as the plasticity and the viscoelasticity. And there are various machines now, the ocular response analyzer, the Corvus ST, and there's dynamic corneal imaging using a Scheimpflug camera and holography interferometric techniques that can characterize these biomechanical properties and help us decide. The ORA now has a keratoconus match index and the probability of the patient developing keratoconus. If we look at the normal signals in an ORA, this is what they normally look like. And if we look at subclinical keratoconus segments, you'll find that there is a blunting, there is more bounce, and the whole ORA is wider because it takes that much longer for things to return to normal. And there are much noisier signals as well. This is the keratoconus match index, and you can see here that this patient has a very high 1.05, which is absolutely normal cornea, and this is the one eye that you can probably safely look at while doing LASIK. If we look at the ectasia and keratoconus, it's a little different from the keratoectasia that I've just described. There is an increase in collagen lysis and a reducible collagen cross-links, but there is no difference found in the collagen composition. Some keratoconus corneas exhibit an increase in glycans, aminoglycans, and polyanions, and there are highly sulfated keratin sulfates stained both in KCN and in pellucid marginal degeneration. So essentially, there is a problem in the corneal collagen and the adjunctive constituents of the cornea that create keratoconus, but in keratoectasia, it's usually a mechanical problem that creates the ectasia. Thank you very much for your attention. Thank you.